Hello, my name is Dr. David Morawski. I am here today to talk to you about my educational seminar for total hip and total knee. Thank you for signing in. And we used to do this seminar live in my office, in my educational room, but since the new epidemic or pandemic, COVID-19, we are now requiring this seminar to be watched and listened to prior to surgery, but online. So thank you. I want to discuss, before going any further, my legal disclosures. I am a partner here at Fox Valley Orthopedics, and I own, partly with my partners, some shares of the Ambulatory Surgery Center across the street at Fox Valley Orthopedics. I also do consulting work for a number of companies, including Globus Medical, Stelcast, Exactech, and some of the other disclosures you see on this slide. I also have a handout for you to sign and return to my office that you've read and signed that disclosure. A little bit about myself. I am a board certified orthopedic surgeon. I started here in 1993. I did my fellowship in joint replacements. Board certification means every 10 years we recertify, we take an exam, we do case lists, and we do self-assessment tests and certain CMEs. So board certification is something that we take very strongly here at Fox Valley Orthopedics. I'm also a specialized total joint replacement surgeon where I did my fellowship in San Diego in 1993. And now I brought all the newest and greatest things, including outpatient hip and knee replacement, to Fox Valley Orthopedics. Discussion today is going to be about total joints. I am going to explain the anatomy of the joint we are going to replace. I'm going to explain what arthritis is. I'm going to recommend that you've tried some conservative treatments and explain what the usual conservative treatments are for your arthritic joint. I will also explain why people have surgery. I will explain what types of surgery there are, and I will also explain what to expect after the surgery. So this is the time to just sit back, listen, and try to digest as much as possible prior to your procedure in the next few days. First, we're going to talk about the knee anatomy. The anatomy of the knee is a hinge joint. There are four bones. The biggest bone in the body is the thigh bone or the femur. The second biggest bone in the body, long bone, is the tibia or the shin bone. The patella is the kneecap. We also have a small bone that you see next to the tibia that doesn't articulate with the knee, but is very important for the attachment of ligaments and the insertion of muscles. The anatomy that I want to discuss now is the two rounded protuberances called condyles. There's a medial and lateral femoral condyle, and it sits above the tibia, and the knee rocks it back and forth like a hinge, just like a knuckle on your finger. And that material that coats and protects the end of the femur and the top of the tibia is called cartilage. Cartilage is a substance that's softer than bone. There's no calcium in it. It will not show up on an x-ray. It's soft, shiny, slippery, glistening. It's like two friction-free surfaces rubbing against each other. When you have an arthritic knee, that knee is no longer smooth. What you have is divots, potholes, scuff marks, grooves, and erosions. You'll have two types of arthritis most people come to me with. The most common is osteoarthritis. This is typically genetic. So if mom or dad have bad knees, you probably will have bad knees. The other type is rheumatoid arthritis. This is an immunologically based disease. This disease affects all the joints that have cartilage, not just the knee or the weight-bearing joints. It affects fingers, toes, and even the spine. So this form of arthritis is treated with immunologically based drugs to help suppress your immune system to defend itself from attacking itself. There are other types of arthritic joints, including septic arthritis, where bacteria can destroy that cartilage. Another form of inflammatory arthritis is pseudogout. Pseudogout is when we find calcium pyrophosphate crystals in the joint. which can act to destroy and inflame the joint and lead to significant arthritis. When we get an x-ray of your knee, what we're going to see, as you can see on this picture, a normal knee should have a space between the two bones. And since cartilage has no calcium in it, it will not show up on an x-ray. So we assume if we see the bone touching the bone, that space where cartilage should be is no longer there, and we must have an arthritic joint. We describe that, as you see on this picture, a bone-on-bone osteoarthritic joint. We oftentimes will add to our diagnostic test MRIs, because MRIs will show us the soft tissues, the things that don't show up on an x-ray, the things like the ligaments, the tendons, the muscles, the bone marrow, to see if there's any bone marrow metastatic disease. All those things help us in planning your surgery. I now want to talk to you about the hip anatomy. The hip is a ball and socket joint. There's only two ball and socket joints in our body. The other is our shoulder joint. The bones involved in the hip joint include the pelvic bone and the femur, which is the biggest bone in the body. I want to talk to you about the ball. We call that the femoral head. The socket is called the acetabulum. The lining of the acetabulum and the lining of the femoral head is coated with articular cartilage. There's no calcium in it. It's the soft, shiny, smooth material that gives us a good and full range of motion. When you have an arthritic hip, that ball and socket is no longer smooth. It's no longer round. It's pitted. It's got potholes, grooves. It's got gouges, bumps. It may be oblong shaped, mushroom shaped. It may be deformed or dysplastic. Not a normal hip. So that's the anatomy of the hip. So now that we discussed the anatomy of the joint, let's talk about why you're here. You're here because you have a complaint. You're here for surgery because you have symptoms, things you talk to me about. And this slide that I'm running now, short video, is of a gentleman getting up from a chair showing all the symptoms that most of you have and why you're planning to have surgery. This gentleman has the symptoms of pain. You could see it on his face getting up from the chair. He has significant stiffness. He's not flexible. He has a lot of swelling in his knees. These are mostly the three top symptoms people come to me with: pain, stiffness, and swelling. But because of those three things, they have impaired mobility. Like that gentleman getting up from the chair, he was using a cane. Some of you come with walkers, with crutches, or wheelchairs even, or scooters. So it's the impaired mobility is a symptom. A lot of you are here because of the quality of life. You can no longer sit on the bench. You want to get out and do things. You want to get out and golf. You want to play tennis. You want to see the world once the world opens up again from the COVID-19. You want to enjoy life. You might have a deformity. You don't like the way you walk. You're bow-legged. You're knock-kneed. You got a giddy-up, a limp, a short gait. You're the slowest walker in the group. They have to stop and wait for you to catch up. So those are joint deformities and abnormal gait patterns. Those are the majority of symptoms. Some people will also add instability. They can't trust their hip or knee. It feels like it's going to give out. It increases their exertional activity. In other words, they're out of breath. It just wears them out. They're tired all the time. So those are your symptoms. Now let's talk about the conservative treatments that most of you have probably tried. Whenever you have an ache or pain, you usually go to your own medicine cabinet and try to self-medicate. Things like aspirin, Tylenol. Those are simple things, over-the-counter anti-inflammatories. But let's start with what I think is the most important thing in conservative treatment, and that's your diet. A lot of us eat inflammatory foods, caffeine, alcohol, all kinds of fatty and processed gluten-filled diets. And those things give us inflammatory not only to our joints, but to our bowels and to our immune system, and even can be cancer-causing agents. So eating nutritionally to help feed our body the right medicine, the right nutrition to prevent inflammation in our body, including our arthritic hips and knees. Along with diet comes weight loss. So if you eat the right foods and eat the right amount of macronutrients and minerals, your weight will come down. And it's well known that if you lose 5 pounds of weight, it's like 30 pounds to your knees. So weight loss will help treat the symptoms of pain, stiffness, and impaired mobility when you have less weight on your joints. Exercise is important. We cannot forget about our muscles. Most people, when they hurt, they just sit in a chair. And what happens is it may prevent your joints from hurting, but it also will atrophy your muscles. So when you do have to call on them to walk upstairs or walk a certain distance from the parking lot, you're out of breath and your muscles are aching. So you have to keep your muscles around the hip and the knee very strong with exercise. Another treatment that most of you are already enjoying is the use of a cane or an ambulatory aid, a walker, a crutch, a cane. All those things will help you and take away the pain by unloading the joint. It's said that when you use a cane in the opposite side of your bad hip or knee, it reduces the pressure on that hip or knee by 50%. The anti-inflammatories that a lot of people use over the counter include Tylenol, ibuprofen, Aleve, and don't forget about injections. Most of you have had cortisone shots, gel shots, or visco supplement, hyaluronic acid. And more commonly now, people are trying to do other alternatives, including platelet-rich plasma and even stem cells. For the unstable knee, we've given braces out to unload the side of the knee that hurts the most and put more pressure on the better side of the knee. Physical therapy. They're great at help loosening up the joints, giving you the proper exercises to gain strength around your hip and knee without hurting them. A lot of times the back or the opposite hip or the opposite knee or the joint below the hip or knee is hurting, and they can help loosen that up and prevent that from being harmed by improving your gait pattern. So those are the things that most people try. And now a lot of people ask me, how do I know it's time? How do I know it's time to consider surgery? And most of the time I tell patients, you'll just know. You'll know when it's time and you'll be here. But what that really means is you've gone through a processing. And the first thing is that you've tried some of these conservative things that we just outlined, and they no longer are helping. Number two, you realize that you can no longer live the life you're living, that you've got too much that you're giving up, and you want to improve something in the quality of your life. Number three, we've discussed that it is your hip or it is your knee. We've done all the proper testing. We've done the right diagnostic tests. We've done injections that have helped it, and we confirm the diagnosis. That's critical. And the last bullet point is probably the most important. It's when you're confident and convinced it's time to do something. It's not the person you're living with, not your loved ones, not your spouse, your children are threatening you. If you don't do something, we're going to put you in a nursing home, or we're going to cut you out of the will, or we're going to trade you in for two younger husbands or wives. You're here because you want to be here. That's the best patient that physicians can have. So how can a total joint replacement help you? Well, first and foremost, it can eliminate the severe pain you're in, or at least greatly reduce it. And the reason I say at least greatly reduce it, because some people who've had hip and knee replacements come into me and say, I still have some pain around my hip or my artificial knee. And the reason is because we do not replace your ligaments. We do not replace your muscles, your tendons, your bursas. And all those things can be inflamed. You've heard of tendonitis. Well, you can get that still around your hip or your knee. So that's the majority of the pain that's caused from the bone on bone, however, will be relieved. By doing that, it will improve the quality of your life. You'll be able to move more. You'll be able to participate in the things you had to sit on the bench for in the past. You'll be walking faster. In fact, many people will come up to you and say, you look a lot younger because you're walking with more confidence. So those are the benefits of a hip or a knee replacement. What is arthroplasty or joint replacement? The term you're going to hear and see in some of your paperwork is the term arthroplasty. Arthro means joint and plasty means resurfacing that joint. So I'm not going to amputate your hip and get a cadaver hip and put in there. What we're going to do is open up the skin and try to go through planes without cutting muscle or tendon and resurface the damaged cartilage and the damaged joint that arthritis has left you with and replace that with metal and plastic. And in a hip, it's titanium and plastic and ceramic without any methyl methacrylate or bone cement. And in a knee, typically, it is titanium and cobalt chrome along with high-density polyethylene and methyl methacrylate, which is the bone fixative. Let's talk about total knee replacement. When you have your knee replaced, what we're actually doing is resurfacing. So on the slide that you see before you, on the left, you see a damaged knee with worn out cartilage and bone spurs. We are not going to cut the ligaments. We are not going to cut the muscle, but we'll resurface that damaged cartilage and the end of the bone and resurface it with metal and plastic like you see on the image on the right. The different types of knee surgery that are out there include the typical traditional 6 to 12-inch incision where the surgeon cuts through the muscle and tendon and exposes the entire knee and then closes that muscle or tendon, and you're left with some soreness and weakness due to the cutting of the muscle and the tendon. I don't do that technique, and I do the minimally invasive small incision, typically somewhere around 4 to 6 inches, and I go under your quadriceps muscle and tendon and do not snip it and do not cut into it, and therefore I do not have to repair it when I'm finished replacing your knee. This leaves patients with a lot less pain and discomfort and a quicker recovery. The video that I'm about to show is of a knee replacement. As you can see, when the knee is opened up, it'll expose the worn out cartilage and the exposed bone. I'll use precision instruments to cut those surfaces and size that knee with the exact size that fits your knee the best so it can have the best motion and stability. It's cemented on and closed up. And when we check x-rays, what you'll typically see is a space between the metal hip or the metal femur and the metal tibia. And then we close that up with suture and typically a zip line on the skin. Okay, let's talk about a total hip replacement. Total hip replacement, before the surgery, when you have a healthy hip, you see the image on your left is of a normal joint with normal cartilage. The image in the middle is your arthritic joint with bumps on the bone and cut surfaces that are ridged and don't fit properly and gives you that crepitation feeling and catching feeling in your hip. So what we have to do is try to recreate your normal healthy hip with an artificial hip, which is an image on the right. You'll see the titanium stem going into the femur. You'll see the titanium shell in your acetabulum. And on the shell is a plastic liner. And inside that liner is the new ceramic ball. And that's a friction-free, very shiny, smooth, slippery surface where you will not have that catching or popping, and you'll have no pain when you put weight on it. Very satisfying procedure to perform, not only for the surgeon, but for the most part for that patient. The different types of hip surgery are many, and the typical types of surgery of the hip are basically three. As you see on the slide before you, you have the anterior hip, the lateral hip, and the posterior hip. Each one of these incisions can be done by myself, and they all can be done through a small, roughly 3 to 4 inch incision. I believe the most important way to have the hip done today, and the simplest and the least invasive for patients, is through the direct anterior approach. As you can see from the three hash marks on the image, the posterior incision goes through that large muscle in the buttock called the gluteus. That gluteus muscle gets split about a third of it. And some of the posterior external rotators also get divided, and that weakens and destabilizes the hip and causes patients to limp longer and not get moving quite as quick. The second incision down the middle or the side of the hip is the anterior lateral approach. That will cut into about the anterior 1/3 of the gluteus medius tendon, and that has to be repaired back onto bone with suture. And most patients have to be restricted from full weight bearing for about 6 weeks. So forget about those two. For the most part, I probably talked to you about the anterior approach. As you can see, the hash mark on the anterior incision goes between two muscle planes. The muscle posterior is the tensor fascia, and the two muscles anterior are the rectus femoris and the sartorius. So this is a demonstration without the muscles of an anterior total hip replacement. It goes through a little bit of the anatomy we spoke of earlier, demonstrating the femoral head and the acetabulum. When you have a normal functioning hip, you have a great degree of range of motion and flexibility that allows you to do many things. However, when it's arthritic, you can't do the things. Even getting out of the car is difficult. So we need to replace it with metal and plastic. So how do we do it? We bring in a shiny acetabulum, a shiny titanium stem, a ceramic head, and we have all kinds of sizes to fit our patients. Patients are brought to the operating room. They undergo anesthetic or a spinal where they're numbed up from the belly button down. They're placed on a special table with their boots on so I can provide traction and move the hip around. I localize the hip with a C-arm or an X-ray machine so I could make the smallest, approximately 3 to 4 inch incision, not a big 12-inch posterior incision. We cut through the skin, the muscle swept to the side, the capsule is encountered, opened up, the hip is dislocated, a cheese grater is brought in to demonstrate how we remove the cartilage from the acetabulum, and we pound in, without screws typically, a titanium shell. The head is cut off, and we enter the canal of the femur and place a stem. We place a ceramic ball on it, articulate it, take it through a range of motion, and check for stability. We take x-rays to check our leg lengths, and if we're happy, we irrigate it and close it. The muscle just falls back together, and we close some superficial sutures. We don't use staples as was seen on that video, but we use a zip line, which we'll get to a little bit later in the talk. I'd like to talk about my rapid recovery program. All of you listening to this lecture are enrolled in what I feel is the most rapid recovery program for any hip or knee replacement. And the reason I think that is because we spend a lot of time on the front end educating patients, just like this video. The first thing is patient education. Watching this video, having the opportunity to ask questions after the video, either calling us or talking to us on your pre-op visit, but also the guidebook that I've given you for hip and knee replacements. Secondly, I prepare my patients not only mentally, psychologically, but also nutritionally. A lot of you have had to either gain weight because you were too frail to properly heal, or some of you may have poor nutrition and weigh too much to qualify for the surgery. As we do know, some patients who are extremely obese have a very poor time healing due to poor nutrition. And because they don't heal well, they're more prone to certain complications that we'll discuss later, including things like infection. Physical conditioning. So physically, we need to get you healthier. That's why we prepare you by giving you instructions on the guidebook on how to get your muscles stronger prior to surgery so that when the surgery is over, you have an easier time getting up and moving. So those of you who are in better shape will certainly recover and return to more normal activities a lot quicker. I've included in the guidebook some of those exercises, and some of you may have even had some pre-surgery physical therapy to get you stronger. The other thing on this slide is how we handle blood. These procedures today are no longer the big incisions and bloody operations, and for the most part are not even very long operations. Many times these surgeries can be completed in 30 to 60 minutes. With that short amount of bleeding, the requirement for blood transfusion is very, very small. So we don't ask people to pre-donate blood like we did in the old days. We ask them to actually don't donate. In fact, prior to their surgery, we recommend not donating blood at a blood drive for the church or for the school or for your blood bank, community blood bank. We want you coming into surgery with the highest level of hemoglobin possible. The other things that are important that I think I do is what we call the home safety visit. All of my patients undergoing outpatient joint replacement, or even those planning to stay in the hospital 1 or 2 nights, typically will have a physical therapist that I've trained personally to come to the house and go over all the things that you need to know to safely come to your home. And that includes getting in and out of your car, how to get in and out safely without dislocating your hip or hurting your knee, what stairway or what entryway to come into your home, maybe some recommendations on where to put a grip bar, what side of the bed to sleep on, how to get in and out of your tub if you don't have a walk-in shower, maybe recommendations on elevations and raised toilet seats. They review the exercises. Just in case you didn't do them on your own, you'll learn the lingo so that when you're not medicated, you'll understand what exercises you should be doing. They also might recommend some additional equipment that I've listed on this next slide. A hospital bed. If we feel your steps getting up to your bedroom is too complicated for you and you're too weak, we may recommend a hospital bed. Today, I believe nobody needs to go to a skilled nursing or rehab facility. I believe strongly that we can accomplish safe care right in your own home. Certainly, I recommend a walker. They're more stable. I recommend, like the image on the right, a wheeled walker. The other things that you may want to buy or purchase on your own are things like a grabber, so you don't have to bend down to pick up the remote control or something that may fall that puts you at risk of possibly injuring yourself, like dislocating your hip. The long shoe horns and the strap that you see that looks like a dog leash is very, very helpful. We call that the leg lifter. That leg lifter helps my patients not need someone to help lift their leg in and out of bed. Even though the surgery is minimally invasive, there's still going to be some sore muscles, and it may feel like your leg feels like 1,000 pounds trying to get out of bed. So that leg lifter assists you in many ways. A raised toilet seat. I like the 3-in-1 commode, the center image on the bottom. So those are the things that the home safety visit will help prepare you for a safe homecoming. The blood management we talked about, we don't pre-donate. We actually check your hemoglobin to make sure you're not anemic prior. And if you are anemic, we have your family physician figure out why. We might recommend iron supplements. We definitely do things in surgery now that we never used to do, including minimizing the tourniquet. On a knee replacement, we used to use a tourniquet for the entire procedure. Now I like to keep your blood pressure very low prior or during the surgery, and then when I go in and I see a small bleeder, it's not pumping really fiercely, it's just trickling out, and I zap it and it goes away. And therefore, you don't have tourniquet pain because ischemia is caused when a tourniquet and no blood comes to your leg. So my patients who don't have a tourniquet, it's another way of having less pain after the surgery and less bleeding. There's a medication called tranexamic acid that we stole from the gynecologist. This is a medicine that they used to give to female patients who had heavy menstrual periods. Now we give it to our pre-surgical patients that are having hip and knee replacements, and it decreases the amount of bleeding during the operation and shortly after. I also use topical agents, including thrombin and gel foam, to help soften and decrease the bleeding on the bony edges that sometimes are hard to get to stop bleeding using the coagulation. And the blood pressure is kept very low by our anesthesiologist so that it can manage the amount of blood loss in that 30 to 60 minute procedure. Post-surgery, it's imperative that you use ice. Ice is cheap, safe, and effective. I recommend purchasing one of these ice machines that will help deliver cold therapy to your joint to decrease the pain, to decrease the swelling, which will in effect decrease the pain and the need for narcotics. Also, compression devices like support stockings for the knee, or maybe compression shorts, the bike shorts or the spandex shorts that a lot of athletes use under their gym shorts to help compress the thigh and keep it from swelling and expanding. That will definitely decrease the amount of pain. So as you can see, the Rapid Recovery Program is not just a minimal incision. It's also a lot of other things, including the comprehensive program, the preoperative visit, and what we do with the medications during surgery and after surgery. Let's talk about pain. I think one of the biggest game changers that I've introduced into my practice about 6 years ago is a local anesthetic called Exparel. Before Exparel came into the picture, the only local anesthetic that I had available was Marcaine. Marcaine lasts typically maybe 6 hours if we were lucky. And after 6 hours, people would start to have a lot more pain because you were still within that first 24 hours of surgery. But Exparel is Marcaine placed in liposomal molecules that are of different molecular weight. So your body has an enzyme called lipase, and that lipase digests these liposomes to release the active ingredient called Marcaine, which I inject all around the joint prior to closing. And that's released over a 72-hour period, keeping it numb and decreasing the amount of discomfort, therefore decreasing the need for large amounts of narcotics. So this is something I call the game changer in joint replacement, and it has led significantly to the advent of outpatient joints. So pain management is multimodal. It's not just a minimal invasive procedure. The first thing that I said earlier is ice. Ice is very important. It chills the blood flow to that extremity, decreasing the swelling, which puts pressure in the joint if it's swollen. Therefore, if you decrease the swelling, you use less narcotics, and you get up and move better, and you feel better. The two different ways to deliver ice is obviously your own ice packs. At Delnor Hospital, they'll give you a gel pack. At St. Joe's, there will be an ice machine delivered there. In our office, we recommend purchasing the ice machine that you see on the right side of the image, which plugs in and delivers cold, chilled water on a continuous basis. Very effective. And those patients who do utilize that, we've noticed significant phone calls and need for refills on prescriptions. The other thing that's important is Tylenol. Tylenol is acetaminophen. Acetaminophen is a central nervous system painkiller. It works on our brain and shuts off the pain receptors that are being delivered to the brain through our peripheral nervous system from the hip or the knee. The important thing here is that I utilize Tylenol or acetaminophen prior to the procedure. So we'll give it in your IV, and so that it shuts off the pain even before the pain is started. And then once you're awake and alert and tolerating oral medicine, you should continue to take acetaminophen around the clock. But remember, you are not allowed to take more than 4,000 milligrams of acetaminophen in a 24-hour period. The other thing that causes pain is inflammation. And we talked about swelling, and ice is important, but there are medications called anti-inflammatories that we utilize. I use two different kinds of anti-inflammatories. First, they're steroids, and secondly, non-steroidal. The first we give prior to surgery in the IV called Decadron. We will utilize that to decrease the swelling even before the surgery starts. It also is very beneficial to the patients who are given certain anesthetic agents. It'll decrease your response and nausea to those medications. So our anesthesia likes to give that. After surgery, when you're tolerating oral medication well, I recommend a steroid pack. As you can see on this slide, you'll take 6 pills the day after surgery, 5 the second day after surgery, 4, 3, 2, and 1 until it's over. That'll decrease the swelling in the first week after the surgery. The other form of anti-inflammatories are the non-steroidals. When you wake up from the surgery and in the recovery room, you may have some discomfort, and one of the first things we give patients is a IV anti-inflammatory called Toradol. And once you're awake and alert and tolerating oral medicine, feel free to use your medication that you normally use for your anti-inflammatory. It could be Aleve, Advil, or a prescription meloxicam or Celebrex. Next is electrical stim. This is an alternative to pain medicine. Many times it's not covered on insurance. I don't know why. I think it's a great way to decrease pain and speed up healing. Electrical stim is when we place 4 pads around the incision, either the hips or the knees. It's shown on the slide here of your knee, and you'll get a unit to take home, and you can use stimulation along with the ice and along with your motion machine that you're using, the GIN motion, to decrease the pain and decrease swelling and speed up healing. We will contact you, and we'll have a representative contact you regarding the e-stim machine and the cost that usually it involves. I usually recommend purchasing it for approximately 3 weeks after surgery. The next item for pain management is fairly new, especially in the state of Illinois, and to adopt it in my practice. A lot of patients over the years have asked me about medical marijuana. And Illinois now feels that medical marijuana is a safer alternative to the use of opioids. Opioids, Norco, Vicodin, oxycodone, Percocet, those things are addictive. It only takes 5 pills to get addicted, where cannabis has a very low or very negative addictive relationship. So most people won't get addicted to it. So there is an alternative program now in the state of Illinois that I can prescribe. It's a program that patients who are eligible, anyone who has an operation that may require opioids, is able to have this prescription and get some cannabis, whether it be in the gummy form or the marijuana as shown on the slide, or vapor. You're allowed to get a certain amount every 2 weeks. You have to go to the same dispensary, and this is only for a 90-day period. After 90 days, if you're still in need of using this after a total hip or a total knee, then it's your option to go to the dispensary and get the recreational cannabis. So I have provided this for patients. The advantage of getting the medical is it will be available because they are not allowed to run out of the medical. And number 2, the taxes are a lot less for patients. And I think it gives us a benefit over the use of opioids. And of course, narcotics. We still will give a small dose of narcotics. We recommend self-weaning and using only what's needed to take away the pain. And there are side effects including constipation, addiction, sweats, nightmares, and not being able to function properly throughout the day, being sleepy. So those are the multimodal pain management. We will discuss for you what's the best treatment and plan for you, and we will prescribe those medications prior to surgery so that you have it and don't have to worry about finding those the day of surgery when you're going home. Let's talk about the dressing enclosure. So I try to simplify even that so that people can take a shower. When people aren't feeling well and have surgery, a lot of times they just want to have a nice hot shower, relax, and unwind. So most of my patients will have a dressing that will allow that. And what I utilize to close the incision is what's called a zip line. Prior to zip line, we used stainless steel staples, which left railroad marks and pin marks, which was slightly invasive. And a lot of patients feared coming to the office on the 2-week follow-up to have my nurse or medical assistant remove those staples because they would pinch and cause some discomfort. Now it's just simple as peeling off the tape. So a zip line, as you see on the slide, is just a little zip tie that we can tighten up so that when you bend the hip or the knee, it doesn't stretch the incision or it doesn't allow the incision to open up. So we'll close with that, and then on top of that, we'll apply a silver dressing. So the dressing has an application of silver, which is antibacterial, and it's water resistant. So a shower can be taken, but not a bath or a hot tub or a swimming pool. And then we will place the pads for electrical stim around that, as seen in this photograph. And then we wrap it up with ABD pads and cotton padding, and the electrodes will be sticking out of the cotton padding, and then we'll wrap it up with the ACE wrap, over which the ice pad will be placed closer to the incision, and you'll see it be wrapped up like this so that the electrodes and the ice pad connection will be sticking out so that when you go home, all you have to do is plug in and go and start utilizing it. So when you take this down 2 days after surgery to take a shower, you'll unwind the ACE wrap, take off your ice pad, you'll remove the cotton padding, you'll remove the ABDs, and you'll leave your silver dressing. You should take off your electrical stim pads, place them on the plastic that comes with it, place them in the freezer so they can be reapplied, and then take your shower. And then you can place your support stocking over that knee. Now the hips are a lot simpler because you don't have all the cotton padding and ACE wrap, and you can just apply your ice pad to your hip loosely. So as far as the next slide is concerned, this is showing how the majority of my patients, I would say closer to 80%, are going home the same day. A lot of my patients will have to stay in the hospital if their insurance dictates it, but for the most part, this slide shows now how we are doing most of these surgeries outpatient and even in an ambulatory surgery center like Fox Valley Orthopedics. And the reason we feel this is effective because we are subspecialized. It's a lot less expensive, there's less infection, people return to their home a lot quicker, and we have dedicated orthopedic staff, not only from the anesthesiologist, but from the pre-op nursing, post-op nursing, and physical therapists. It's all we deal with is ambulatory orthopedic surgery. Now it's time to talk about the potential complications of your surgery. Every surgeon has a duty and a responsibility to tell their patients not only the potential good things that a surgery can bring to them, but also the possible complications that are associated with these surgeries. Now, it's important to know that hip and knee replacements are very popular procedures, and millions are being done every year. So some of these complications that we're going to speak of are the things that are most commonly associated and potentially could happen around these operations. And I just want to assure you that they don't happen frequently. In fact, the percentage of these complications in total is about 2%. 98% of the patients do very well without any issues. But sometimes an issue will arise, and it's best to be prepared if it does, because those people who have heard of this possibly happen really deal with those potential complications, which sometimes are unavoidable and happen. So let's, without any further ado, discuss that. I cannot do the procedure without anesthetic. Now, there are two types of anesthetic. A general anesthetic, where the anesthesiologist gives you medicine in the IV and puts you completely to sleep. That involves placing a tube into your throat and into your windpipe and breathing for you. The other option is a spinal anesthetic or a regional anesthetic, where a needle goes in your back, Novocaine type of anesthetic goes into the spinal canal and numbs you up from the belly button down. A very safe, effective procedure, and therefore using that, you don't have to have as much medication and probably won't get as sick from that type of anesthetic. But both have risks, including nausea, vomiting, increased heart rate, decreased heart rate, arrhythmias, increase in blood pressure, or decrease in blood pressure. The anesthesiologist at the institution you're having your surgery will discuss that. I can tell you that I prefer the spinal anesthetic. I think it's a nicer way to wake up from the sedation when you still have numbness in your legs and you can start to deal with some of the discomfort that comes as the numbness goes away when you're awake. The second potential complication is bleeding. Even though the procedure is a lot less invasive than it used to be, it's still considered one of the major orthopedic reconstructive procedures that we do in modern medicine. It's one of the most successful operations, hip followed by knee replacement. However, bleeding can occur. The biggest bone in the body, the femur, is opened up and it can bleed. And it depends on whether or not you come into the surgery with a high blood count or a low blood count. So if you're starting with your tank full, most likely you won't have a problem. But if you're frail and anemic to begin with, and we run into a little more bleeding than expected, there's a potential for a blood transfusion. Now, blood transfusions are safer than they used to be. We have tests for all these bad diseases, including HIV, COVID-19, and hepatitis, but nothing is 100%. Infection. This is the biggest one that I want to spend the most time on. I do everything I can to prevent infection, and that's including optimizing you. Getting your weight down below a BMI of 40, because obese patients have a heavier or have a increased risk of getting an infection. We test every patient for a methicillin-resistant Staph aureus through a swab in your nose, and we treat it to decontaminate you if you are positive or a carrier. We ask you to see your dentist prior to this procedure because the dirtiest part in our body is our mouth. And some patients just won't go to dentist, and they might have a flare-up or an infection or a rotten tooth or gum disease that could get infected into their blood and then go into their artificial hip or knee and cause a major problem. The other things are diabetes. People who are not well controlled in their diabetics have a greater risk of getting an infection. We do everything we can, including IV antibiotics, right dosed within 30 minutes of the incision. We do the procedure in an operating room with high exchange rates, HEPA filters. Everyone is masked and gowned and actually use a bubble or a spacesuit for protection against contamination, cross-contamination. I happen to wear 3 pairs of gloves, and one of them is Kevlar's to prevent me from getting cut and bleeding and contaminating you, and vice versa. We pour antibiotic irrigation. We do the procedure as quickly as possible. There are studies that show that surgeons who have long operative times have higher infection rates. So the more your joint is exposed to the open air, the higher risk of an infection. We close it up and we don't use staples because those pin marks can cause entry site for bacteria. We use a silver dressing on the skin to help fight infection. We get you out of the hospital or don't even do the procedure in the hospital because that's where people come when they have infection and disease. So that's important. We do everything we can, but you can still get an infection. It could be a stitch abscess or a deep infection with a pocket that has to have a required operation to wash it out. And the worst case scenario is if we have to take the joint out and remove your artificial hip or knee and place a temporary cement spacer in there. And that requires then IV antibiotics for roughly 6 weeks until we eradicate the infection in the joint, and then we can go back into surgery and remove the cement spacer and install another artificial replacement. Hopefully none of you will have that, but we have the potential to salvage those joints if that happens. So the best part of this is getting yourself optimized prior to your procedure. The other thing we talk about is blood clots. Those of us who don't get up and walk are higher risk than those who get up and walk. So ambulatory surgery decreases the risk of blood clots. Blood clots occur in the calves and usually lower legs due to sludging, due to trauma from the surgery. That causes pain and swelling and the inability to put pressure on your leg. If you think you might have a blood clot because you were able to walk without pain one day and the next day your foot is swollen and painful and you can't bear weight on it, then call us and we'll send you to one of the outpatient centers where you can have an ultrasound of your leg to help diagnose that. And to prevent that, we recommend ankle pump exercises, walking frequently, and support stockings, as well as a pharmacological agent that will decide what's best for you. So if you tell me you've had blood clots in the past, it'll be most likely that you'll be on a very strong pharmacological agent to thin your blood. If you've never had a problem with blood clots or no family members have had blood clots, then we'll probably use a low-dose aspirin, like 81 milligrams twice a day for 6 weeks. That also goes for the reason why we don't want you to travel for 6 weeks, because blood clots become a factor when you're sitting confined in a flight across the country or across the Atlantic. If a blood clot dislodges from the lower extremities, it can travel and go to the lungs. That's called a pulmonary embolism. And the symptoms are chest pain and shortness of breath. I don't want you to call me, call 911 and get to the nearest emergency room. I want you to not drive yourself there or wait for your family member to come home and just lay down on a couch. That would be the wrong thing to do. You call 911, the paramedics will give you oxygen, they'll travel to the nearest emergency room, you tell them you had surgery and that you're short of breath, they will order a CAT scan of your lungs and probably reserve a room in the ICU where you'll have blood thinners put in to thin the blood, dissolve the blood clot, to restore your breathing to normal and decrease the chest pain. Most of those patients who recognize this will get to the emergency room, get treatment, and usually leave the hospital within 2 days of admission on a blood thinner for maybe 6 months. But it's better than ignoring the symptoms and not getting treatment, which could lead to fatality. Another potential complication is the breakage of instruments we use to place the implants into you. Some of the cutting jigs, some of the saws, the drills. Those things are brittle sometimes in your hard bone and can break and get dislodged into the bone. Even though we didn't mean to keep it in there, it may do more harm than good trying to retrieve it. So we let people know that sometimes these things happen, and usually they don't usually cause any major complications or anything, but it doesn't make for a pretty x-ray sometimes. Malalignment. We do everything we can to measure 3 times and cut once and then re-measure again. But for some reason, some patients may still come a little bit off. One leg may be longer than the other, or slightly angled into knock-kneedness or bowed-leggedness than we really wanted. That usually leads to an earlier wear of the product. This is an example of a leg length discrepancy on the hip. We usually use a line drawn from the bottom of the pelvis across to the femurs, and as you can see, the hip replacement side, the line is higher up, and meaning the leg is lower or longer. So this is a severely longer leg on the reconstructed side. This would not be a good thing and would require the use of a leg lift. The other thing we see for potential complications are dislocations. If in the early healing period, the first 6 weeks, when the capsule is rehealing from when we had to enter the hip, you could pop the hip out of socket. You will know because your leg will hurt, you will not be able to put weight on it, and it will be rotated or flexed to the side. Sometimes patients have a kneecap that pops over to the side. That also will feel like a quiver, and it may feel like your knee buckles. So both of those can be diagnosed with x-rays and may require, or for sure on the hip side, that will require sedation and someone pulling on the hip to put it back in the socket. Sometimes we then place a brace on your knee or your hip to prevent it from reoccurring until it heals properly. Occasionally, sometimes people are recurrent dislocators, and if any of my patients happen to dislocate 3 times in any 12-month period, we may be talking about revision procedures to prevent it from happening. Premature wear or loosening. I tell my patients these current hip and knee replacements should be lasting 20 to 25 years. I've had a couple people even longer. This is an example of a hip replacement that's almost 30 years old. She was 58 when it was put in. She's 88 now. And you can see some polyethylene wear or plastic wear as the ball is starting to migrate up into the socket. I told her this could require the need for a revision, but at 88 she wasn't having it. She said, I probably won't last as long as my hip. So I warned her, we'll see what happens. I haven't heard from her at all recently, and that was maybe 2 years ago. The other potential complication is stiffness and scarring. This goes for my knee replacements. Typically, we recommend icing, electrical stim, motion machine, physical therapy, but sometimes patients become stiff. As seen on the slide before you, this patient had to have a manipulation. She only received maybe 90 degrees of flexion after about 6 weeks. I took her back to surgery, numbed up her knee with a local anesthetic while the anesthesiologist put her to sleep. I did an aggressive physical therapy, stretched the knee, and broke up the adhesions and scar tissue to allow it to flex. Now you can see the gravity drop test is closer to 120 degrees, which is what we achieved during the surgery. The next complication is nerve injury. I know exactly where your critical nerves are around the hip and the knee, but I place metal retractors, hand them to my physician assistant to carefully retract while I can perform the procedure. Sometimes those nerves get irritated or rested on by the retractors, and that could injure the nerve, sometimes temporarily and sometimes permanently, which could result in the loss of foot function, or what we call a foot drop. Sometimes a foot drop, in order to walk properly, will require a ankle foot orthosis, as seen on the slide before you. Femoral nerves can also be irritated with the anterior hip replacement, and that will result in the lack of knee extension and may require the knee of a knee immobilizer to be utilized until the nerve can recover. Most of these injuries from retractors are only temporary, but it can last for up to 2 years. Vessel injury. I know exactly where your blood vessels are, and I know exactly where to place those blood vessels or place those retractors. But sometimes those retractors will push on the vessels, occlude them, and restrict the blood flow to your lower extremity, resulting in either lack of circulation, poor wound healing, infection, gangrene, maybe even the loss of a limb. It's rare because now we have very good consultants like our vascular surgeons or our interventional radiologists who will be on the case trying to restore any occlusion through either angioplasty or stents or even bypass surgery. Lastly, the last complication to end all complications is death. This is an important one. We ask you to see your primary doctor, to tell him the truth. As you can see on this slide, minimizing the risks, the first thing on the slide is seeing your primary doctor, and I tell my patients it's better to lie to your priest than it is to your family doctor, because if your family doctor tells or asks you, do you get short of breath when you walk up a flight of stairs, and you say no, but you're lying, then they won't send you to the cardiologist or won't order that stress test. And then you get clearance, and the anesthesiologist puts you to sleep or does a spinal. I do the procedure, and your heart can't take the stress, and you pass because of that. So that's an important point. I think a lot of times patients just want to get through the procedure and not really pay attention to the preoperative testing and things that are so important, particularly in the patients that I operate on who wear out their joints. They typically have older hearts and lungs and need to have a good medical evaluation. Secondly, is the dental work. I ask my patients to see their dentist because there's a correlation of medical health and dental health. Those of us who go to the dentist every 6 months will, on average, live 4 years longer and healthier than those who don't. So see your dental professional, get the clearance, get them straightened out, and remember, for the rest of your life, when you see your medical or your dentist, you will need to have antibiotics given to you prior to your procedure. Prepare your home. Please allow the physical therapist to come into your home and discuss preparing your home for safety. Make sure that if you're the person that has to do the cleaning or the cooking, that you have someone do that during your rehabilitation. Make sure you don't try to get out there and cut the grass. Hire somebody to do that, or shovel the snow, or whatever it may be. Try to prepare yourself and take a little planning, and that will help prevent potential complications. And lastly, make sure your bowels are regular. I don't know what it is about anesthetic agents, lack of mobility, narcotics, the medicines that you're taking. It can obstruct and slow motility of your bowels. So I recommend picking up a bottle of Miralax, which helps decrease the constipation associated with surgery. I want to let you know what to expect after the surgery. So these next few slides will describe that. First of all, it's very important to understand that there will be, this is not a complication, this is an expectation. Lateral to your knee and to your hip, you will feel numbness and tingling because the small nerves to the skin will be cut. Any surgeon who does hip or knee replacements should tell you that, because some people are surprised that it feels numb in that area. So that's normal. Now, I can tell you from experience and having knee surgery myself that numbness will decrease over a period of time, but it still feels a little different than the non-operative side. Secondly, a knee replacement can click. They're made of metal and plastic. You can feel it. They're superficial, and they're put in not too tight, so there has to be some flexibility, otherwise the knee would not bend. So there is some clicking that you can feel or hear, but it won't be loud enough to wake up your family who's sleeping or anything like that. But it sometimes is noticeable to others, but mostly you will because it's in your body. Thirdly, you can kneel. It's a myth that you can never kneel after a knee replacement. The incision will be tender and sore, and I don't want you to kneel for the first 3 months. But after 3 months, go ahead and practice on a bed, a mattress, a padded kneeler. And you have to dedicate the time to try to decrease the sensitivity of the knee by putting a little bit of incremental increased pressure on it at a time until you finally can kneel. But recommended is knee pads or a cushion, particularly for gardeners or people going to church. You should expect mild to moderate swelling that can last for up to 3 to 6 months. That's normal. The response to surgery is to send blood flow to the affected hip or knee. And that blood has to go all the way to the hip and knee, down to the foot, and back up. I recommend using those thigh-high support stockings for 3 weeks after surgery, but some of my patients like to wear them longer, particularly on the side that was operated on, because that extremity will tend to be puffier for up to 3 to 6 months. That's normal. Knee motion. Although I showed a slide of somebody who needed a manipulation after 6 weeks when she only bent maybe 90 degrees, but some of you may come to me at their 6-week or 3-month checkup and you have 110 degrees. And I told your family you bent 120 or 130. I believe that after 3 months, you still have a good 9 months to get that 1 or 2 degrees every month to finally get the resting degree of about 125 to 130. So remember, it takes a whole year sometimes to get the final resting mobility and strength in that artificial joint. And that goes for hips too. A lot of times there's weakness, particularly in the hip flexors, getting upstairs or getting in and out of car. Sometimes there's a little anterior soreness and weakness, and it doesn't feel quite as strong as the other hip. And that takes sometimes up to a full year. And like this slide shows, there could be a lot of bruising. Remember, you're going to be on some sort of blood thinner. You're usually fair-skinned. You might bleed or bruise easily, and it'll show up on the skin. And there's enough bleeding under the skin that it'll turn pretty colors, purple, yellow, green, and so on. So this surgery is important, and there are some risks, but if you go through that, you will get your life back. You'll enjoy things again, like walking on the beach, like this couple just showed. The other thing is when to recognize you have a problem. It's important to understand, I introduced my staff earlier in this lecture, we're here for you. Please call us if you have excessive bleeding. We may have to have you come in and change the dressing if it's bleeding through. If there's severe pain in the calf and you can't put weight on it, it might be a blood clot. Call us. We'll schedule you to get the ultrasound and further diagnostic testing. If there's severe pain, the medicine may need to be adjusted. Or if you have a fever, particularly over 101.5, or nausea or vomiting, could be related to your medication. But remember, it's critical that if you have chest pain or shortness of breath, don't call me first. Call 911, get to the hospital, and have someone call me and let me know. A lot of people ask me, when can I return to normal activities? When will I be normal again? Well, it varies on different people, what normal is. Some people just want to be able to walk normally to their mailbox. Other people want to walk 18 holes of golf. I typically tell people that about 6 weeks is the average time where you'll be able to golf, walk the dog, and do long things again. I've had patients who come to me at their 6-week follow-up and tell me they've played 8 rounds of golf already. I have others saying, I'm not sure I'm ready yet. So it's an individual basis. As far as driving is concerned, if I operated on your right leg, most of those patients take about 2 weeks before they drive. If I operated on your left leg, the average time to driving is about 1 week. Swimming, 6 weeks. And remember, I want to make sure your wound is healed before any swimming is allowed. Some things that you shouldn't do. You shouldn't run, jump, jog, or contact sports, or heavy manual labor. So those are the things that I'm sure you can do after a hip or knee replacement, but you shouldn't do because it'll only decrease the longevity of your joint replacement. Follow-up visits. It's imperative that we see you. I don't want to do the surgery and never see you again. These are implants that need regular follow-up and x-rays to make sure there's nothing going on behind the scenes that you don't recognize yet. Typically, my staff, meaning my medical assistants or PA, will see my patients at the 2-week and 6-week checkup. The 2-week follow-up is to remove the zip line for you and get a quick set of x-rays to make sure there's no early problems with your implant. The 6-week checkup is usually to figure out how your therapy is going, how your walking is going, and hopefully you're off of all your narcotics at this time. Then I'll see you at your 4-month checkup, make sure you're progressing well, And then your 1 year anniversary, your 3 year anniversary, your 5 year anniversary, 10 year, 15, and so on. I want you to remember at this time, during all those follow-ups, you need to continue to get antibiotics for any dental procedures or dirty procedures like a colonoscopy. You can obtain that prescription for antibiotics from me, or you can call your dentist or other physician. So in closing, number one, a proper diagnosis is essential to identifying what the cause is of your joint pain. Remember, ladies and gentlemen, there are options other than joint replacement, but we can cure arthritis with a joint replacement. We cut it out. The affected joint won't grow back bad cartilage. You can get other problems like infections in an artificial joint or loosening or wear, but it won't be arthritis again. Remember, the benefits, however, must outweigh your personal risks. And lastly, it's not over when the surgery's over. This is a commitment to regular follow-ups and checkups to test and to look at how the life of the implant is doing. So this is all I have for now. I want to thank you all for your attention. I wish you a happy and a speedy recovery.